Morning and welcome to Progress 2022. It is a great pleasure to have the faculty, an amazing national faculty with us, and also to invite all the participants. As you all know, Progress has been existing now. Next year, it will be 30 years. We started in 1993. Every 2 years, we had this conference, and it has been received extremely well. We started with about 400 delegates, but by the time the last few progresses, we were hitting between 800 to 1,000. The reason for that is Progress stands for Practical OG Congress. It was entirely based on the fact that any practitioner who comes to Progress should be able to go home with practical tips, not esoteric knowledge, something that they could actually use in their own practice, in their own small hospitals, anywhere in India. We were always India-centric. We brought in knowledge from everywhere, but we were always India-centric. And in fact, most people have noticed that Progress never used to have speakers from abroad. Well, I wouldn't say never, but very rarely had speakers from abroad, unless that topic was something that we could actually use and utilize in India. We did not have people coming from there. Many of the panelists today and the people who are taking part have been part of Progress for many years, I think for almost all the years. And in fact, I'm very proud to say that those youngsters I chose to speak at Progress went on to become national and international lecturers and speakers, and were recognized for their talent. We will now go ahead, and I would like, because this time we are doing Progress along with OGSI, the OBGYN Society of Southern India. And I would like to start with the OGSI prayer. Dr. M.G. Dhanalakshmi will now do the OGSI prayer. Thank you, Dhana.
Dhana, unmute, please unmute. Dhana, unmute.
Yes, ma'am. Thanks for the opportunity, ma'am. Thanks for including OGSI. Thank God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect. And to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love.
Thank you, Dhanalakshmi. I now request Premlata, the president of OGSI for this year. This is the last month as president, and I'm so glad that both Premlata and Dhanalakshmi, the secretary of OGSI for 2022, have been part of this program. They are both extremely amazing. I have seen their work, and their teamwork is fantastic. Premlata, could you just welcome the delegates to this?
Thank you, madam. Thank you for the very good words given to this. Good morning to one and all. On this pleasant morning, I bring greetings from OGSI to all. I'm really very happy that OGSI is being associated with Progress series of conferences today. And I'm really very happy that we are able to be associated with the launch of the book, A Practical Guide to Obstetrics, second edition authored by Madam Geeta Arjun, madam. I'm really very happy that OGSI is, as Madam told, the OGSI 2022 team today will be our last webinar for this year, and next month, Dr. Jayarani Kamaraj is taking over. I welcome one and all. I welcome Dr. Nazir Zarier, who has come here, joined here for launch of the book. Is a very dynamic personality from Foxy. Welcome you, sir. I welcome Dr. Shobha Gudi from Bangalore, Professor Lakshmi Shetty, madam, and I'm seeing Dr. Sheila Balakrishnan, Dr. Sarina Gilwas, all from Sheila madam from Trivandrum, and Dr. Sarina Gilwas from Trishur, all national faculty. and other faculty who have assembled here. And Oxy is very happy to welcome one and all for this webinar on practical problems, the solutions for it. Welcome one and all. I thank Madam, and we'll go on with the next proceedings, Madam.
Thank you. Thank you, Premlata. Sheila, your lighting is not okay. Could you just check on that? Also, we will now do one more thing that we have consistently done in progress, and which is to have youngsters be introduced to the country actually as speakers. And for this, I now invite Sneha Sethumadhavan. Sneha, could you please turn on your video and audio? Sneha, you could do your screen share now. Sneha, I met recently because she was part of the Yuva Oxy program, and she impressed me immediately. And she is now junior consultant at CSI Kalyani General Hospital, which is very close to where I practice. And you can understand why I was impressed well before I even knew that she had won the Mary George Gold Medal for Best Outgoing DGO Student from CMC, the Dr. Bhaskar Rao Gold Medal in OG for DNB final exam. You know, Sneha, he was our idol. We worked with him and he was just amazing. And you are very fortunate to have received the gold medal in his name. The Mrs. Indumati Jhaveri Prize and the Dr. Sneha also delivered the Dr. Jayashree Gajraj Yuva Oxy oration. I am very, very pleased to introduce Sneha to you. And I would like Sneha to now go ahead and talk about a topic that we don't talk about most often, but it's something that we can come across in our practice and we need to be updated about it. And she is going to tell us about intrahepatic cholestasis of pregnancy. Please go ahead, Sneha.
Thank you, ma'am, for that very kind words of introduction. Good morning, one and all. It gives me a great pleasure today to be giving a small talk on updates in intrahepatic cholestasis of pregnancy. As complicated as the names of the disease sounds, this is, put in simple words, a disease that affects the liver, specifically when the woman is pregnant. And it is also unique in a way that once she delivers, the disease completely resolves. It's a reversible disease as well. Various studies conducted among women in India have shown an incidence of around 0.7 to 1.5%. You can see that it is not a big number. It is not a common disease, not something that we see day in and day out in our practice. That makes it even more important for us to know about this disease a little bit in detail so that we do not miss the diagnosis and we know how to manage it so that we can prevent the adverse outcomes or the implications associated with this disease. So, intrahepatic cholestasis of pregnancy, to put it in very simple words, is a disease that affects the bile acid secretions in a woman's body. So let's briefly look into the physiology before we start discussing the etiology that can cause this disease. The cholesterol in our body is converted to bile acids in the liver cells. These bile acids combine with proteins, a process that we call as conjugation, and this combined product is then secreted in the gallbladder as bile. What happens during cholestasis? Some women have genetic predisposition where the transport of these bile acids into the bile is affected, leading on to increased bile acid levels in the hepatocytes, which then spills over into the plasma. The second important cause is the hormonal changes that occurs very specifically during pregnancy, the most important one being increase in the estrogen levels. This causes increase in cholesterol synthesis, which later on leads to increase in bile acid level, which again is excreted into the plasma. This is the reason why this disease is quite common during third trimester, when estrogen level peaks, and also in multiple pregnancy when compared to singletons, because they have a higher estrogen level when compared to singletons. Another hormonal change that occurs during pregnancy is the presence of a compound called sulfated progesterone. This combines with the proteins which were originally supposed to conjugate the bile acids. And now the free bile acids are not able to be secreted into the bile, and this is again excreted into the plasma. So the bottom line is that there's an increase in the bile acid levels in the plasma, and this is what kickstarts the disease process in the woman. Now, this increased bile acids can have effects both on the mother as well as the baby. When you come to the mother, the most common symptoms that they might present to us in the OP is itching or pruritus. Typically, they are seen over palms and soles, and they can progress to abdomen, torso, and rest of the body. It might be so severe that they might have sleepless nights, and they're characteristically not associated with any skin lesions. They will just have scratch marks. Sometimes they might also present with GI symptoms such as right upper quadrant pain, nausea, or decreased appetite, and you might notice mild jaundice on examination. Increased bile acids in the fetus can cause sudden death of the baby in utero, a dreaded complication that we would definitely like to avoid. But a recent meta-analysis has shown that the rate or the incidence of stillbirth is similar to someone with a normal pregnancy, a low-risk pregnancy. And in fact, the incidence is increased only in women with bile acids of more than 100 micromole per liter. The other complications include preterm delivery, either iatrogenic or spontaneous, meconium-stained liquor, and prolonged NICU stay. Now, laboratory investigations are also an important part of evaluation when a woman comes with pruritus, and this will usually reflect the symptoms that the patient comes with. As already mentioned, the first and the most important parameter that needs to be measured is the serum bile acid, and this will be elevated usually to more than 10 micromole per liter. Liver function tests such as AST and ALT might also be elevated, but usually the elevation is very mild. It will be less than 2 times the normal value. And bilirubin, the total and the direct component of serum bilirubin, will also be raised, but it will hardly exceed 6 nanogram per deciliter. This is in comparison with other liver disorders such as viral hepatitis, where you will see a very severe increase in the liver function test. Some parameters such as alkaline phosphatase might also be elevated, but this is highly non-specific and not usually used for diagnosis. And there might be increase in prothrombin time in some women. This is because of vitamin K deficiency that is associated with this disease. As we all know, vitamin K is a fat-soluble vitamin, and the bile acids that is present in the bile is important for the absorption of this vitamin from the gut. When the bile acid gets decreased in the bile, vitamin K is not absorbed, leading on to vitamin K deficiency and hence increase in prothrombin time. Coming to the diagnosis, this is a combination of what we have seen so far. So if you see any women with pruritus, especially in the 3rd trimester, associated with an increase in bile acids or LFT, this is when we can diagnose the condition. But an important point to note is that most of the time, women present with pruritus. This will be the first characteristic thing that they would present with, and it might take a few days or week before the bile acids or the LFT starts increasing. So in the first presentation, when a woman comes to us with pruritus, when you measure the bile acids or LFT, it might be normal, but it is very important to repeat the blood parameters weekly so that you do not miss the raise in these parameters and so that the diagnosis is not missed, and also to pick up the patients who will have the high bile acids level who are more prone to have stillbirth. Also, as already mentioned, this disease resolves completely after delivery. So it is important to note the resolution of the symptom as well as the biochemical parameters once she delivers. Coming to the management, for the mother, our major aim is to relieve her of the pruritus. Apart from the topical agents that's available, ursodeoxycholic acid has been found to be very effective in decreasing her symptom. but a lot of studies have shown that it does not have any effect on controlling the negative outcome or the adverse fetal outcomes associated with this disease. It is usually started at a dose of 300 milligram twice a day, increased up to 500 milligram twice a day if she's not relieved of symptoms in the first few weeks. A lot of literature also suggests that there's a promising effect of adding rifampicin as a second-line drug if the symptom is not resolved with UDCA. Drugs such as cholesterone, S-adenosine, methionine, and dexamethasone are not recommended for the treatment of intrahepatic cholestasis. For the baby, what we are worried is the sudden in utero death or the stillbirth. And we do know that there are a lot of antenatal fetal surveillance techniques that are available now for monitoring the fetal well-being, such as NST, A5, or Doppler. But unfortunately, when you come to intrahepatic cholestasis, so far we do not have any valid indicators which will help us to predict if the baby is at risk of sudden intrauterine death. To prevent this complication of stillbirth, we usually plan for the delivery at as close to term as possible at around 36 weeks. We can even plan it earlier if she has very severe non-responsive pruritus, severe jaundice, or if the bile acid levels are more than 100 micromole per liter. You can definitely plan for a normal vaginal delivery. Induction of labor can be offered, and this condition is not an indication for cesarean section. When you come to the role of vitamin K, we did see that in certain patients there might be increase in prothrombin time. And in such patients, you can offer them water-soluble vitamin K to avoid hemorrhagic complications of labor. Postnatally, it is important to counsel the patient regarding few points. She can exclusively breastfeed the baby. It is important to document the resolution of disease, both symptomatically as well as biochemical parameters. So you need to repeat the LFT or bile acids. But please note that this is usually done after 10 days of delivery because a slight increase in LFT is considered normal in the first 10 days of postnatal period. It is also very important to stress that she might have a significant risk of recurrence in her next pregnancy, up to 60 to 70%, so that she'll be prepared. And also, it was previously thought that when it comes to contraception, estrogen-containing pills can aggravate the disease, but now we can provide her with low-dose combined OCPs. It does not trigger the disease very significantly, but it is important that you monitor the LFT regularly once in 3 to 6 months. And if at all the patient develops symptoms suggestive of cholestasis, you can provide her with alternative contraceptions such as progesterone-only pills. So I would like to end my talk by stressing on few important points about this disease. Since it's a rare condition, we should have a high index of suspicion when a woman presents with pruritus, especially in the third trimester. But please remember that there are other dermatological as well as hepatic conditions that can present in similar way. So we should have other differentials in mind as well. Coming to the management, for the mother, our aim is for symptomatic relief. And for the baby, our aim is to prevent stillbirth and to plan for delivery at around 36 weeks. Thank you so much. I would like to thank Geeta ma'am for this wonderful opportunity and also for her guidance and also the OPSI group. Thank you, everyone.
Thank you, Sneha. If this was an in-person conference, you would have heard the applause because you did a fabulous job. And as I grow older, I find the younger ones are getting smarter and smarter. And they're also what I loved, because you know I'm a stickler for time. And I've been watching, you did a perfect job in perfect time. Thank you so much. It was a delight. It was beautifully presented and very clear. Clarity was excellent. Thank you so much, Sneha. I can understand why you got all those gold medals. So we will now progress again directly to our next part of the program. And I'm going to share my screen. We are going to talk about one second. Right. We're going to have a panel discussion now on fibroids in pregnancy. Now, just remember that the universe conspired to make sure that no doctor or surgical doctor was unhappy. They gave cataracts to ophthalmologists. They gave the useless appendix for surgeons, which is a piece of flesh which has absolutely no use except to make surgeons rich. It has given tonsils for ENT surgeons. And of course, we cannot ever forget that fibroids, which have no reason for existence, have been put on earth or in humanity, in the human race, particularly for women, so that obstetricians and gynecologists will have something to do, okay? So there's no doubt about it. So before we start, I would like to introduce my problem solvers, Dr. Shobha Gudi, Dr. Premlata, Dr. Rajshri, and Dr. Ramya Jairam. What can I say about Shobha? When I first met her in one of the Bangalore conferences, I was so impressed with her absolute down-to-earth way of looking at obstetric and gynecological problems. She is the head of the department at St. Philomena's Hospital. She has a huge body of work. In her career, she has achieved so much. And one of the things I like about is the fact that she is on the Lakshya. She is part of the assessor for the GOI, Government of India project, Lakshya, which is very, very close to my heart. So Shobha will always come up with absolutely correct decisions and ways to solve a problem. Premlata, you have already met. She is, again, I have known her for more than 30 years, ever since I was in Oxy, and I have seen her grow from a young, confident obstetrician and gynecologist to somebody who has now headed Oxy in a very, and has shown really good leadership qualities. Rajshri is my pet. She has been with me for many, many years, worked with me for many years. More than 10 years. And I believe that she's one of the finest obstetricians practicing in Chennai. If you look at her cesarean section rates, you will understand why people look for her, go looking for her when they say we want a vaginal delivery. She has been my support throughout my career not throughout, but for the 10 years of my career at E.V. Kalyani Medical Center. Ramya is, I would say, in a way, the daughter-in-law of our house. You know, Dr. Mridubhashini and our family has been really almost family, not just friends. So when Ramya came into their family, she also came into our family. She's again very, very focused on what she does. She's an excellent laparoscopic surgeon, and she has specialized in performing MR-guided focused ultrasound surgery for uterine fibroids, one of the first few people who specialized in that. And she's truly an expert in that. So I thought she would be definitely should be part of our fibroid panel. So I just want to start off with, my problem is that I'm not able to, how do I move this panel of, just hold on, please.
We are seeing the slide.
No, I know, but I'm not able to see the screen properly. It's okay. So Mrs. HR came for a preconceptional checkup. After 4 years of marriage, the couple had decided to go ahead with the pregnancy. In preparation for the planned pregnancy, she had a master health checkup and was told she had fibroids. They obviously both were very concerned. She had seen 2 other gynecologists, and one of them had suggested a myomectomy. So panelists, I will just be asking a focused question to each of you. So if anybody wants to join in later, you can always put in your viewpoint also. On examination, the uterus felt bulky and an ultrasound was done, which showed 4 subserosal fibroids, the largest being 4 by 3 centimeters. So Shobha, Is it unusual to see women with fibroids in the reproductive age group? And what would your advice be? Shobha? Shobha is there? Okay, we'll go on to, can you see me?
Yeah, ma'am.
Shobha, are you on? Where has Shobha disappeared?
Shobha, madam?
Shobha, can you hear me? No. Okay, Premlata,
Yeah.
why don't you go ahead, answer that, please.
Nowadays, we see more women with fibroids in pregnancy because of the advanced age and the delayed childbearing. And as age advances nearing 30, 35 and all, we see fibroids in reproductive age group, and it's around 10%. It just varies depending on the age of the women who become pregnant. And when a lady comes with this, with fibroids, more of subserous fibroid, and she's married for 4.5 years, I know they're very anxious, but subserous fibroid per se may not interfere with fertility, and she might, she's postponing the pregnancy. I don't know whether go ahead with pregnancy only after 4 years. Now only she's planning for pregnancy. And with subserous fibroid, she can become pregnant. But the size of the fibroid, actually, if they say it's 4 to 3 is the largest fibroid. Subserous fibroids need not be operated when they are planning for pregnancy, but we have to counsel them, saying that fibroids during pregnancy can cause pain, and a pedunculated fibroid may rarely go for torsion.
But at this particular point, you're not going to say, go ahead and get a myomectomy, right? Yes, so Rajshri, the couple has been trying for a pregnancy for 6 months. Should she be investigated with laparoscopy and hysteroscopy? Because there is subserous fibroids. Do you think it could be causing a tubal block? Should we be doing any other tests on this woman? She's been trying only now for 6 months.
6 months. No, ma'am. Right now, I would not advise her to go for a hysteroscopy or laparoscopy. It's a subserous fibroid. It's not going to interfere in the pregnancy in any way. And it's been 6 months only. I would not advise her to go ahead with any of the investigations now, now.
Right. So, Ramya, would a myomectomy be done at this point, or would you even think of an MR guided surgery at this point? Because she's now 29, 28, I think, and she's been married for 4 years. Should we do anything about this now at this point?
Yes, ma'am. So, we have very good options like the MRI, which can be used to map fibroids. So MRI is a very good modality to be able to map the fibroids, see the number of fibroids, the position, location of the fibroids in relationship to the cavity as well. So once we do an MRI, we can also decide based on that whether it is a viable fibroid and decide whether we need to really do MR guided ultrasound for her.
Okay.
But myomectomy is really, again, like how my previous panelists mentioned, if it is away from the cavity, it is really not going to interfere with the pregnancy, and myomectomy will not be required.
Right. Okay. Sorry, it's not my, right. So we know that, Prashant, can you tell me how I can move my panel to the right? The video panels. It's all on top, my video panel.
We are seeing clearly, madam.
No, I am seeing, but I'm not able to read my slides. Can it come on the side? How do I move it to the side?
Side, it's not possible. It's just come in the center only, ma'am.
Okay, all right. Right. We know that fibroids, as you all said, they have been found to be associated with menstrual disorders and pelvic pain and can negatively affect fertility and pregnancy outcome, but mostly it is submucosal fibroids, which can cause fertility problems. And when we look at the reproductive age group, The fibroids are there. As I said, the universe has conspired to put fibroids, and they're like warts or moles. You have them. And it's not unusual to have 1 or 2 fibroids or even more, because 35 to 77% of women in the reproductive age group can have fibroids. Right. So Srimati HR came back after a year. She was now married for 5.5 years. She had consulted 3 more gynecologists. Her mother-in-law had taken her to one. She visited an uncle in Pune, and he insisted that she see their family gynecologist there. Her husband's boss said he had the best gynecologist for his wife, so he took her there. But now she had, seen 3 more gynecologists. She had undergone treatment for infertility, but she had conceived spontaneously. She presented at 7 weeks gestation. So what are the chances for normal outcomes in a woman who has fibroids in pregnancy? Shobha, are you back? Are you on? Okay, Premlata, what are the chances for normal outcome?
The majority of these women, they go and they have a very good outcome. I mean, for more than 75%, they have a normal outcome during pregnancy. And usually the submucous fibroids, large fibroids, and multiple fibroids, these are the types which usually they go for pain or problems during pregnancy. And these subserous fibroids, they don't impact, but subserous fibroids can have pain during pregnancy, and that may be because one of the complications during pregnancy, but majority, they go well. And this.
What about the outcome? Ultimately, what happens? Can we expect any problem with the fetus? Any issues as far as outcome is concerned?
Usually these fibroids, because of fibroids, the fibroids can increase in size hardly in 20 to 30% of women, especially in the early pregnancy. In the first 10 weeks of pregnancy, there may be increase. Otherwise, usually there is not much increase in the size, and the increases are only hardly 10 to 25% of the size of the increase is found. And they have found that it regresses in the second and third trimester also. So as such, fibroids may not increase. And coming to pregnancy has, because of the fibroids, they have slightly increased instead of miscarriage, preterm labor, premature rupture of membranes. And they can actually have, if it is a fibroid which is impacting in the pelvis, it can cause malpresentation. The large size fibroid can have cervical, they may have pressure symptoms like urinary retention. All this kind of pelvic pain can occur during pregnancy.
Right. But Rajshri, if you had a woman with fibroids, would you tell her that her outcome, there could be an issue with her, the outcome, will it put her pregnancy at risk?
No, the fibroid that this particular woman has is a serious fibroid, will not put her at any special risk. Majority of them will go through pregnancy normally and deliver vaginally. Yes, she may have some pain, minimal bleeding if it is, if there is a submucous fibroid and there is, if this fibroid grows and the placentation happens nearer to the fibroid, she can have a minimal bleeding in early pregnancy. The risk of spontaneous miscarriage is extremely low. And again, because the fibroids are small, we need not expect anything like a preterm labor. There will be no problem as far as the fetus is concerned. And we could expect a normal presentation as the fibroid. There are not, though there are multiple fibroids, the largest one is only at 4, and we could expect a cephalic presentation. Just because of the fibroid, it need not be an abnormal presentation, and we could allow her for a trial of labor and normal vaginal delivery if other things are fine.
So the bottom line is the majority of women with uterine fibroids will have a normal pregnancy outcome. And this is something important because I believe that we should not be starting off a pregnancy by frightening the woman. That's the first thing that happens is you've got fibroids, you've got the whole family, the relatives, the next door neighbor, everybody is frightened her. You've got fibroids. Oh my God, something's wrong with your pregnancy. But we have to remember that the majority of women will have a normal pregnancy. So we did an ultrasound and it confirmed the presence of a single viable pregnancy corresponding to 7 weeks. There was a 5 by 4 centimeter fibroid near the left cornu. There were 3 more sub-zero sulfate. So obviously these fibroids have grown. As Premalita said, in the first trimester, the growth can be a little bit more rapid. There were 3 more sub-zero fibroids, 2 by 2, 3 by 2, and 3 by 3 centimeters. There was 1 3 by 3 centimeter intramural fibroid, but it was not impinging on the gestational sac. On examination, the uterus felt like a 12 to 14 weeks gestation. So Ramya, do you think she has an increased risk of miscarriage because of the fibroids? Particularly, there's one large fibroid near the left cornu.
So again, ma'am, though, if they are subserous fibroids, I will not be very concerned, especially if I've done a scan before, I've already mapped the location of the fibroids, then I will just keep an eye on it, especially in the first trimester. But the fibroid that I would be slightly concerned about and follow a little closer would be the 3 centimeter intramural fibroid. It may not be impinging into the cavity, but if it is still in the myometrium, I would be, I'll keep a closer eye on that fibroid just to follow its growth in the first trimester.
Correct. So Premalita, here's this woman who's of course, she's tried only for a year and she's got pregnant immediately, spontaneously, but she's got fibroids and her mother-in-law has told her to stop working, not go to office. She's told her to stay at home because it's a precious baby and that she has fibroids. So would you advise limited activity?
Madam, I understand these are the people who come to us and always want to know whether they can even climb the stairs, they can sit down. All these questions are asked. But
Right.
as such, restriction of activity need not be advised. And just by arresting, they can have normal routine work which they are doing. Maybe you can advise her to avoid strenuous activity, which nobody does nowadays. So regular activity she can continue. And the role of vaginal micronized progesterone, actually, see, progesterone per se may not be useful for any women just because she's having a fibroid. But in the context, I think any women coming with fibroids and that is in the intramural fibroid, I think I may be putting on our progesterone till 12 to 14 weeks.
What about you, Rajshri?
No, ma'am, I will not be placing her on vaginal micronized progesterone. She's conceived spontaneously and if she has conceived with ART and then if it was required, yes, just for the sake of fibroid, I'll not be placing her on vaginal micronized.
So Ramya, since your family, your hospital deals with infertility, would you be placing this lady on micronized progesterone?
Definitely not, ma'am, because there are a lot of studies that are coming up now that says that the fibroids have 3 times more progesterone receptors than the regular myometrium. So when you add on progesterone, so this is a misconception that people think that if you add progesterone, you can keep the uterus quiescent. It doesn't cause increased uterine contractions and you're protecting the pregnancy. But you actually may be doing more harm than good by adding on more progesterone.
So this is very important to know that out of a study from 2017, where they looked at 20,000 women with fibroids, they found that there was no increased risk of miscarriage. But of course, we know that there is evidence to show that multiple fibroids may increase the miscarriage rate as compared to the presence of a single fibroid. But here's a woman who's, as you said, we have to keep an eye on the intramural one. But other than that, mostly she has done well. She has conceived spontaneously. We just have to keep reassuring her family, everybody concerned, that this is a pregnancy we are going to follow as we would follow for anybody else. We are not going to give it any extra treatment or advice for that. When we finished giving her dietary advice, finished talking to her, examined her, gave her everything, whatever she needed for her first antenatal checkup, her mother-in-law said they wanted an MTP. Of course, this just blew my mind, because the previous obstetrician, who was an infertility specialist, mind you, had told them that her risk for miscarriage was very high. She had advised her to undergo an MTP, followed by a myomectomy for the fibroids, and then proceed again with a pregnancy. And this is the truth. This is the actual thing. This is not something which I dreamt up. This girl was in tears because obviously she and her husband had planned for everything. She had, said that this is what they waited for 4 years, then tried for a pregnancy, got pregnant. And now her mother-in-law said, we have to go back to that other person who has said you need an MTP. This baby will be affected. The mother-in-law in her imagination thought the fibroids would grow and do something to the baby. Does this even seem logical?
No, madam, we have to clearly tell them that this is not going to happen, and with the tender loving care, actually we have to continue the pregnancy till term, and we will advise the mother-in-law that we have counsel them well that very slightly increases of preterm labor, and that especially in women who are having submucous fibroid and distorting the cavity. Otherwise, majority go well, and we have to explain to them.
Yeah. Good morning, Dr. Geeta.
Shobha.
Yeah. Can I come in here?
Yes, please.
So
Please.
MTP has no ground here. It has absolutely no application because very unfounded fears they are having. And undoubtedly, a lot of crosstalk is going on in the family circle, and people are, just building up the fear factor. So they need to understand that they should not be afraid of fibroid, and the very fact that she has conceived and she has progressed till here, it means that there is a friendly environment inside for the baby to grow. And rather than an MTP, it is better to continue the pregnancy and take it as it comes. I think that should be the positive message given to them.
Thank you, Shobha. We missed you for a little while.
Yes, my connectivity was poor. I'm so very sorry.
No. We missed your wisdom. That's why.
Thank you. Thank you.
Right. So obviously we reassured the family that she could continue with the pregnancy and that her chances of a normal outcome were excellent. And several reviews, Segars and colleagues found that the majority of women with uterine fibroids have normal pregnancy outcomes. And also a review by Parker concluded that myomas only very rarely affect pregnancy outcomes. So there is a misconception among women who are pregnant that as they grow, the uterus will also grow along with the baby. Okay, they think that it will have an impact on the fetus. Shobha, do fibroids grow in pregnancy?
Well, very marginally. Some of them grow, most of the growth happens very early on, so we can make out actually. But then most fibroids behave themselves in pregnancy. They are quite friendly to the obstetrician and the patient. And quite a few of them have the kind of, the characteristic of flattening themselves out and moving out of the way of the fetus. So in my experience, I have not found alarming growth in several women, maybe a very small percentage of women.
Right. Yeah. Does the size of the fibroid have anything to do with the growth, Rajshri?
Yeah, ma'am. Fibroids which are more than 5 centimeters, larger fibroid tend to grow a little more as compared to the other smaller ones will not grow. So if the fibroids are large in the beginning, they may grow a little bit more as compared to the smaller fibroids. And the growth will be in the late first trimester and early second trimester. After which, as Madam has said, it will flatten out. And there should not be a problem because of the fibroid.
Right. So Premlata, what happens to this fibroid after delivery?
Majority, like more than 90%, there is slight regression of the fibroids after delivery. And the rest of them, they just stay. There is no increase in the fibroids, especially if they say, as Dr. Twini, in the postnatal period, if you are putting them on progesterone only contraception, those are the things that slightly increase growth in the fibroids. Otherwise, majority have a regression.
Right.
In the postpartum period.
Right. Ramya, you saw this table earlier in the book. So could you just explain what's happening there?
Basically, ma'am, the fibroids that we are concerned about are the intramural fibroids, subserous, and subserous fibroids generally don't undergo too much of change in pregnancy. So the initial part in the first trimester, most of the fibroids are stable, but there is a small increase in about 20 to 30%. And then, after that, they either stay status quo. And once, in the postpartum period, some of them regress as well.
Right. Okay. So she had an uneventful pregnancy. She had a spontaneous vaginal delivery at 38 weeks. The mother and baby were fine. This is another girl. We still stay in touch. Srimati GR, 24 years old. She presented in early pregnancy for confirmation and antenatal follow-up. She had, when we examined her, she had a uterus about 16 to 18 weeks in size. On ultrasound, she was found to have a 7 by 6 centimeter fibroid in the posterior wall near the fundus. She presented at 22 weeks of gestation with a history of severe, sharp, and continuous abdominal pain. She was in agony. On physical examination, we found tenderness on the right side of her abdomen, but no signs of any peritonitis. The gravid uterus was soft with a palpable mass at the fundus. There was no vaginal bleeding. So what could be the causes for the pain, Premalata, since you were talking about pain that can happen? What could be in a woman with fibroids? What could be the causes of pain?
The most common pain for fibroid in pregnancy is just because of the growth of the fibroid. The fibroids may just grow, and it overgrows the blood supply to the fibroid is less. It overgrows the blood supply. Thereby, there is a ischemia and necrosis, and that cause pain. Another cause of the pain may be the fibroid may be stationary, but because of the increase in the myometrial growth, there is a kinking of the blood supply, causing ischemia and or necrosis. So all this causes release of prostaglandin. Thereby, there is a pain in the women during pregnancy. So a pain may be just because of the growth of the fibroid or a kinking of blood supply. It could be due to red degeneration, especially it's more common whenever it is they say the subserous and pedungulated fibroid, a red degeneration can occur. To say whether this cause of pain, clinically the patient will be having pain, tachycardia may be there, and if there is a tenderness, rebound tenderness, it could be due to red degeneration. And we can confirm by doing a blood test, and also the CRP may be raised, tachycardia, blood counts, WBC count will be raised. And by ultrasound, we can see the degenerative changes in the fibroid if it is a red degeneration.
Right. So it could be a red degeneration of the fibroid, or if rarely a torsion of the pedunculated fibroid. So Shobha, how would you manage red degeneration of fibroid in pregnancy?
Essentially, this is a patient who will require admission, and then good hydration with IV crystalloid infusions, a lot of reassurance, and pain management. So pain management, essentially, we could look at NSAIDs to begin with, non-steroidal anti-inflammatory drugs. And in case that we are not getting optimal relief along with acetaminophen, of course, paracetamol infusions, then we could go ahead even with the opioid analgesics. These are self-limiting situations, and by and large, if we wait it out, the woman does get relief in about 3 to 4 days. And persisting pain still to be managed with analgesia. Very, very rarely there is a setting for an epidural analgesia. But otherwise, apart from this, there is no need to panic. Probably an ultrasound can be done to reassure the family and the woman. But apart from that, it does not require any major intervention. Even antibiotics are thought to be, unnecessary in such cases. So that is the message I wanted to.
Right. I was about to ask Ramya if she was going to use antibiotics, because they do present sometimes with a low-grade fever.
Yes,
your opinion on antibiotics and this?
Yeah, yes, they do. And sometimes we do find leukocytosis as well on the CBC, but we need to hold on because this could be a result of the same, an aseptic inflammation or of the fibroid, which will resolve with given time. Yes.
So Ramya, do you agree or disagree with Shubha?
I definitely agree, ma'am. Actually, sometimes we had a patient where we were worried whether it was actually red degeneration or whether it was an appendicitis. So, the counts are off and she presented with a low-grade fever. So we, did an ultrasound, picked up, saw the vascularity of the fibroid, tried to identify whether it was undergoing degeneration. And then once we figured out what it was, we put her on, paracetamol, observed her, admitted her for a day or so, and, she settled down.
Right. So what would be the problem with NSAIDs, Rajshri? Would you be a little concerned about if you are using it? Because, and which NSAID would you use in a pregnancy? What would you be, preferred NSAID be?
Ibuprofen would be preferred, madam. 400 milligram, 8 hourly. All NSAIDs can cause oligoamnias. So we'll have to monitor the fluid. We'll have to check the fluid around the baby, and we'll have to stick maximum of 48 hours, not more than that. NSIs have to be stopped after that. Just to tide over the crisis, we can use.
Right. And this is something that all of us must keep in mind. You'd be surprised at how quickly the fetal kidney responds to NSAIDs and may kind of shut down, and you'll go in for severe oligohydramnios. So if you're using NSAIDs in pregnancy, we have to be extra careful about it. So after conservative management of the red degeneration, GK had one more episode of pain at 29 weeks of gestation that required hospitalization. She went to term without any further complications. At 36 weeks, the fibroid, when we did an ultrasound, showed a 10 by 8 centimeters. It was 10 by 8 centimeters, and you could see a central degeneration. Now, that's a fairly large fibroid. Premlata, can she be allowed to have a vaginal delivery, or should she be offered a cesarean section?
Well, if this lady has a cephalic presentation, no other complication, apart from that, no obstetric complications, I may prefer to give a trial of labor, madam. And if there are no other complications, she can have vaginal delivery. Degeneration now per se is not an indication for electrocesarean section.
I'm not even going to ask the other panelists. I don't think any of them would do a cesarean, right? Right. So it's been shown clearly that most women with fibroids will have a successful vaginal delivery. A trial of labor should be offered unless there is a clear obstruction. I mean, obviously, if there is a reason, failure to progress or breach or transverse presentation, obviously we're going to do a cesarean. And but unfortunately, there is a higher cesarean section rate in women with fibroids across the board for some reason. Maybe it is the obstetrician's concern or stress that there is a large fibroid. And even the presence of large fibroids, more than 5 centimeters, should not be regarded as a contraindication to a trial of labor. So obviously, we have to give the woman the chance for a normal delivery. Now, in this particular case, she came back and wanted to have a myomectomy because she said, I don't want to have another pregnancy where this would, again, I would get degeneration. Is that an option? Would you be doing, Rajshri, would you offer a myomectomy or just wait and watch that fibroid?
Wait and watch, madam. Let her take time postpartum. Let's see what happens. She is conceived without any problem. We'll see twice. Yes, she has got admitted with red degeneration during pregnancy. That's because the fibroid has outgrown its blood supply. So we can wait and watch for at least 3 to 6 months after the delivery to decide on what needs to be done with the fibroid.
Okay. Any other suggestions of?
Yeah, I agree with Rajeshri completely, because I think postnatally this fibroid may reduce in size because considerable part of it has become ischemic. And once the pregnancy vascularization has gone away, this might reduce in size, and then it may become inconsequential actually, or even if it bothers, it is more amenable through a laparoscope to remove it. So that will be a better decision, and she should be reassured that actually. So myomectomy during cesarean needs to be a very strategic one, and the decision, and we need to tell the woman that all fibroids need not be removed at cesarean. Yeah, thank you.
Premlata, would you remove this? If suppose she had a cesarean, would you remove this fibroid at surgery, at cesarean?
I will just review her I will counsel her prior to her in the antenatal period itself. If it's going to be a large fibroid in the muscle, myometrium and intramural fibroid with a large base, I may not venture to do. It's more of subserous fibroid or in the line of the incision, then I may be doing a myomectomy. But I will counsel her earlier, ahead in the antepartum period, if feasible and it could be accessible, then I will do. Otherwise, I will not do, and I have to think.
Correct. Because there has been a systematic review and meta-analysis, and it shows that women undergoing myomectomy during a cesarean section had greater falls in hemoglobin and higher risks of requiring blood transfusion than women who did not, because it's no question, there's no question about it. It's very tempting. If it's a pedunculated fibroid, maybe it's just to put a clamp and remove it. I think it's fine. But otherwise, I think we have to think very carefully about doing a myomectomy during a cesarean section. Thank you all. Thank you so much. And we will now take questions if there are any questions.
Thank you, ma'am.
Thank you, madam.
For the kind
Thank you, ma'am.
introduction and for
Thank you
including
very
me
much.
in
Thank you
the
very
panel.
Madam,
Thank you.
I just want to know, everybody don't give progesterone. I mean, every person, pregnant woman is having flooded with progesterone, whether we like it or not, it has been. And a lady coming with a fibroid and just pesters us. I think progesterone is not given to, it's like a placebo or whatever thing has been given. I just your idea, madam. Get the madam.
Come like
Premlata, all my entire career, I have never given progesterone for preventing miscarriage. And our miscarriage rate was the same as the rest of the world. Okay.
Yes.
And there is enough data. We are not, and we are going back to it again. And I think 1964, Goldziher published a paper saying that progesterone had absolutely no place in threatened miscarriage. And if from 1964 that has been around, why are we being carried away by pharma
Yes, madam.
advertisement? Because it's the pharma company which is pushing micronized progesterone. Of course, that it has a role in women who have undergone IVF, where their progesterone is low, but otherwise the uterus, the placenta is pouring out progesterone, pouring out more progesterone than you or I can give to the woman.
Yes,
why do we, and it's not cheap, Premlata.
But I understand, madam. I'm just trying to find out, because 30 years back, whatever the threatened abortion, we just used to give some anxiolytic and leave her, counsel her. And things have changed. Any lady coming from, she's traveling long for her work, they want something to be given, so they don't go for abortion. Like that, is the pressure is more on us, and just by the patient and by the team. Just I'm asking that.
Yeah, sure, Premlata. But also, if you say pressure on you, my issue is that our practice never dropped. I had to keep turning away patients,
Yes,
and I never gave progesterone. So,
thank you, madam. Thank you, madam.
You know, that's what I mean. I think we all have to stick to evidence, and I think that that's the whole focus about this entire thing. And I agree with you. There is pressure, especially for youngsters who are starting, and the seniors tell them, oh, if you don't give progesterone, she'll go to another doctor. That's fine. I was also young when I started, and at 29, and I said, well, if they're going somewhere else, their loss, not mine. Okay. So if there are any questions, yeah, I can see questions there.
Any guide about post-myomectomy pregnancy mode of delivery? Somebody has asked, madam.
Right. Shobha, would you like to answer that? Shobha, are you on? Rajshri, can you take that?
Yes, ma'am. Should plan on a pregnancy at least 3 to 6 months after a myomectomy, not before that. The chances of rupture is extremely low when it is an open myomectomy done. The chances are a little more higher if it is a huge fibroid, large fibroid done by laparoscopy, as the opposition may not be as good as opposition suturing, may not be as good as doing it over laparotomy. And the mode of delivery, you could plan the same vaginal delivery if she goes into labor. If you're planning a cesarean section, if it is a previous cesarean, then we'll have to plan a delivery earlier, somewhere between 37 to 38 weeks, 6 days. But if it has gone up to the cavity, if the surgery involved the opening up of the cavity or a huge involvement of the myometrium, then delivery as early as 36 weeks is also advised.
Ramya, since you have done MR guided treatment of fibroids, surgery for fibroids, what happens to those? Can they, if we are talking about myomectomy, surgical myomectomy, what do you think about delivery after for a woman who has undergone that procedure?
So we've had about 15 patients who conceived after MR guided focused ultrasound for fibroids and adenomyosis. So majority of them went in for a normal delivery. They had, they conceived either by IVF or, some of them conceived spontaneously. The only reason for a C-section was either a maternal indication or, fetal indication. But otherwise, they never went in for an elective section, or, the modality didn't change because of the procedure that we had done.
Okay, that answers, I think, a lot of people who are thinking about that. It answers a very important question, because if we do that and then she ends up having to have a cesarean because of that procedure, then you have to rethink everything. There is a question about a little bit more PPH, higher risk of PPH in women who have had a fibroid in pregnancy. Premlata, do you have any?
Yes, madam. Because of the contractility is reduced, sometimes they have increased atonicity of the PPH. And they say if it's a lower segment fibroid, sometimes a retained placenta can also occur. So we have to anticipate, and active management of third stage should be taken. Some instances where the uterus is very lax, we may be forced, we may have to do a uterine artery ligation, or sometimes internal ligation has been found to be needed, necessary.
Right. Okay. Dr. Nagaraj, one of our consistent attenders of Progress. Dr. Nagaraj, you have asked whether myomectomy in LSCS, or you have said that it is safe now due to vasopressin. So the thing is, my take on this is that if you are an excellent surgeon with experience and you have dealt with complex surgeries before, you could probably do it. But on the whole, I mean, I just put up that meta-analysis. When you take it across the board, and that's the importance of looking at meta-analysis, because it doesn't take small numbers, because if I do 5 cases and somebody else does 5 cases, another person does 10 cases, we put it together and we know what the results are. Whereas if I'm an excellent surgeon, I can probably do a myomectomy with very little blood loss, I can get away with it, but we can't suggest it as the common denominator for everybody. So therefore, as of now, even today, I would suggest that we don't do myomectomies during cesarean unless you have got some certain experience and certain level of expertise. So I would not suggest this as a routine. I would not want somebody who has been practicing for 10 years and has, goes in there, because the woman could lose a huge amount of blood. She could also lose her life. So this is something that I would say, yes, you can attempt it if you're very sure about your surgical skills, and definitely train others with that. But what anybody in the panelists agrees with me or disagrees with me?
So just on in preventing preterm labor, one question is there.
Oh, I didn't see that. Oh, Dr. Nagaraj, preterm labor is a whole different thing. Yes, we give progesterone in women, and that's given intramuscularly. But in women who have had preterm labor, which has been proven in the previous pregnancy, yes, you started from 16 weeks. PPH drill is important. Yes, I agree. History of open or lap myomectomy in primigravida, we have talked about that. Rajshri explained that. Medical therapy after some months. If it's not causing her any problem, why do we need to do anything? And especially since the fibroid will regress anyway during the puerperium. Role of ecosprin in pregnancy, Rajshri.
No matter. Unmute Rajshri.
Role, ma'am. No role for ecosprin.
No role.
With fibroids. No role.
I agree.
Premlata, right.
I agree.
ma'am.
I agree. There is no
reason.
role.
Yeah,
There is
yeah.
no role. Yeah.
Yeah, Shobha, you're back, Shobha. Thanks. Yeah, you're again, yeah, there is no role. There is no reason for adding ecosprin. So I think that's the questions, and we are on time, still running on time, exactly on time. We will now go on to a very, very important part of this program. Could I have the introduction slide for my very, very dear friend, Nozer Sheriar. Could I have Prashant, can you put up the introduction slide, please? Now, Nozer, again, is very, very, very dear to my heart. He is a person who has inspired me over the years. Very cool, very calm, very collected, such a good human being. And he is the consultant at Breach Candy, Hinduja and Holy Family Hospitals. He was the past Secretary General and past MTP chair for Foxy. He was the past president for the Mumbai OBGYN Society. He's a fellow of the he's FRCOG. He has won the Young Gynecologist Award at AOFOG, and it should not surprise any of you that he was first in all his exams and has won all the gold medals in MD, FCPS, and DGO. And many of you have heard him at Progress. He was one of my go-to speakers. We did not plan our Progress program without thinking of Nozer. And Nozer would always, in fact, would call me and check with me and find out when Progress was so that he could keep the dates free. He has edited 16 books and published 40 papers and 70 chapters. And the most important thing that he has done now, he has published Finding the Balance, which is a lovely, lovely book. And if you haven't, please buy it. It's for women. It explains a lot about perimenopause, and doctors need to read it because then it helps you talk about perimenopause to your patients. And if you have a woman in perimenopause, please ask her to get it. It's already an Amazon bestseller. It was just released last month. It's already an Amazon bestseller. So welcome to my very, very dear friend, Nozer. Prashant, we can stop this screen sharing. We can get back to Dr. Nozer.
Thank you so much, Geeta. My God, it's so great to be back in a Progress program, really. Geeta, Dr. Premlata, and Dr. Dhanalakshmi, OGSI is always one of the special societies for Foxy. Dr. Lakshmi Sheshadri, and all my dear friends of Progress that I'm seeing here, and of course our delegates. And Geeta, you're so spot on when you said that you'd expect these many delegates, which is excellent for a time when people are really, really, kind of overwhelmed with all the webinars there are. I love obstetrics. And I love that Barbara Rothman said, birth is not about making babies. It is about making mothers strong, competent, capable mothers who trust themselves and know their inner strength. Obstetrics originally comes from obstere, to stand beside. And we are unique in the animal kingdom in the fact that we invariably require some assistance. But while obstetrics needs us to abide by its origins, what we have today is the need to remain up to date and evidence-based. And who better to do this than my dear friend Geeta? Geeta is inherently a teacher. I have always seen that whatever she does, she makes sure that there is value for the delegate, for the student, for the reader, which is not often, because when I've often seen conferences organized, I always say conferences are organized for faculty, not for the delegates. Geeta has always done things for the delegates. And, she is one of my friends I can look to for an honest opinion. She tells you very nicely how it is. She is not going to tell you something she doesn't believe in. So Geeta, it's been a privilege. It's been a long association, and I look forward to keeping this association for the rest of our lives. OGSI, I'm so glad you're part of this program. I mean, for me, Foxy is always special. With all Foxy's weaknesses, it's probably our strongest organization. And to have a society like the one in Chennai, one of the founders of Foxy, where Foxy was founded on the 6th of January in its first AICOG. It's always special for me to be a part of any program by the OGSI. I'm also seeing other friends here. Shobha, Geeta, I must say, Shobha is probably one of the best chairpersons Foxy has had. And
Yes.
the reason she's one of the best chairpersons is because she again does things not for personal glory, but for the cause. And that's what makes all the difference. So I first came into Progress in 1999. And Geeta, you did pick a relatively young person. 1999 was also the time I just stepped onto the ladder in Foxy. And this was one conference I looked forward to. It was apolitical, it was value, it challenged us in the faculty. And I can tell you over the years, I missed one because I had to attend an IPPF meeting. And I remember you holding the oration for me, which I had to deliver 2 years later on what women want, which is my favorite oration. I've seen faculty tested, I've seen faculty retained, and I've seen faculty sent off with a smile and a handshake. And that's so classic Progress. And it's been privileged to be a part of your core team. And we're looking forward to your next physical Progress. Meanwhile, let's keep doing it virtually. Geeta's books. My all-time favorite for my patients is A Passport to Healthy Pregnancy. If patients, patients still ask you where to go. If you want your patients to be well-read, and I have no problem with patients going online and patients Googling, though there's a lot of misinformation out there, as long as they work with me to interpret it. But if I was to recommend a book, and I have a library of books for women, I believe we should read everything women read. But my first book recommended for women is the Indian book, A Passport to Healthy Pregnancy, and not the What to Expect and not the Pregnancy Bible. And this will always be a bestseller. And whenever I look at the list on Amazon and still see the book there, I'm so happy. I was there in Chennai at the release of the first edition of A Practical Guide to Obstetrics. It was wonderful. I have my signed copy from Geeta. It was 10 years ago. It was a book with a difference. The light bulb, the thumbs up, the thumbs down. It was so practical. It was so easy to follow. And believe me, if it's a very easy book to implement in practice, and if we do so, you are even medico-legally safe. Just leaf through the book, anything in the book, look at those little tables, and that's what's going to protect you. Now, a decade is probably the best time to review and update. Certain things have to be reiterated and certain things have to be changed. And I'm truly delighted, privileged, and honored to be here today to release formally the second edition of the book, A Practical Guide to Obstetrics.
Can I ask all the faculty members to turn on their videos? And if you have the copy with you, could you just hold it up, please?
Yes. So I have gone through the book very quickly. I have looked at our older book and seen the changes and the developments. Amazing work. I know sometimes it takes a pandemic to make us do all this and sit down and write. And maybe that's one of the very few benefits of the pandemic. 53 chapters. There are more chapters than there were last time. There are topics which now needed to be added and they've been added. As in the last book, the diagrams are so simple and so well done. Every word, and really every word, is weighed and meaningful. Every recommendation is completely evidence-based and nobody can fault you on anything in your practice if you follow this book. So I know we probably need to do our bit to make sure that this, because Geeta won't, we have to do our book to make our bit to make sure that this book is there. I'm going to make sure that everyone who works with me, who I know, gets to know about this book. I'm going to make sure that it's there in all our hospital libraries. And I wish this book It's amazing author, all success, and success so that the women we care for can benefit from everything that's written in it. So thank you, Geeta. Thank you for considering me worthy of being here to release this amazing book. I know you could have had anyone in the world. I know you had Professor Arul Kumar doing it and Vincenzo doing it. So I'm truly privileged to be doing this. Thank you.
At the age of 70, you still have the power, my age of 70, you still have the power to move me to tears of joy. Nozer, that was such a lovely welcome to this book. And I don't think I could have had anybody else release this book except you. You're not just my friend, you're my inspiration. You have been such a person to look up to, because you and I practice the same way. We believe the woman comes first, nothing else. And that's why I have been waging this campaign for always doing the right thing for the woman. And that's what is reflected in this book. I thank you so much, Nozer. I can't even begin to tell you how grateful I am to you for releasing the book. I would now request Dr. Sudha Ganesh of Universities Press to say a few words about the book.
Thank you, Dr. Geeta. Good morning, welcome, and greetings to the esteemed panelists, distinguished faculty, and students attending this webinar. I am Dr. Sudha Ganesan, Managing Consultant, Medical Publishing of Universities Press. It is indeed my privilege on behalf of Universities Press to share this moment of the book launch of the second edition of A Practical Guide to Obstetrics by Dr. Geeta. This title has been a highly respected and valued one in our medical list. Universities Press prides itself on selective and high quality publishing. It is an absolute pleasure to work in tandem with someone like Dr. Geeta, whose vision is clear, standards are high, and execution perfect. I can literally see the nods across, panelists, everybody agreeing with me. She pushes the editorial team to work towards publishing a high quality product, which is exactly what we like at Universities Press. Well-researched, trusted content for practitioners suitable for the Indian demography is a valued resource tool in the busy world of obstetric practice to enable the practitioner to make quick, evidence-based decisions in the interest of their patients. A well-presented book one can reach for in confidence is a much valued guide. A Practical Guide to Obstetrics has been built with exactly that vision in mind and is supported with several features for easy reference. Now, who better to tell us what this book holds and why it is special than Dr. Geeta Arjun herself. I now request Dr. Geeta Arjun to guide us through the features of her book. Over to you, ma'am.
Sudha, thank you for the kind words. So I must thank all of you, all my faculty, all the people who are listening in to this webinar for making this day very special for me. This book launch is extraordinarily important. As Nozer said, this book needed revision, and the COVID pandemic actually put a little bit of a halt. And then I found out that because we started the book in 20 and we were supposed to bring it out in 2019, supposed to have brought it out in 2021, but everything came to a halt, everything stopped, everything slowed down. And then I also found that things were happening on the medical scene, medical literature, medical research, which needed to be reincorporated. So luckily for me, I have a phenomenal support from Universities Press, and however much I bugged them and made them change and change again, Malini Gopalkrishnan, who's my editor, just stupendous, impeccable editing. and Sudha Ganesh and Mr. Madhu Reddy of Universities Press, they supported me through all the iterations of this book. We have been doing a book launch at Progress since 2011. We started with the management of labor when Professor Arul Kumaran, who was the lead editor on this, he had asked me to become an editor, which shocked the heck out of me, basically, because I was not a professor, I was not in a medical college. And it was an amazing learning curve for us, and it was received extremely well. And in fact, it still sells well. And the good news is that we are now working on bringing the 4th edition of the Management of Labor. In 2013, we brought out a practical guide to obstetrics. Again, as Nozer said, it was very well received, and I will explain to you why this book has become so popular. In 2015, Lakshmi and I brought out Essentials of Obstetrics, one of the big undergraduate textbooks right now. And in 2017, I brought out the new edition, the 2nd edition of Passport to a Healthy Pregnancy, which again, fortunately for me, women have responded to. It has resonated with Indian women, and they feel that instead of turning to a book which advocates things that people don't understand, has no context as far as Indian culture is concerned, women have turned to this book. And more importantly, husbands have turned to this book because they felt very comforted by the fact that it is very focused on Indian women, Indian culture, Indian myths, all the grandmother's tales, which completely confuses a pregnant woman in India. So what makes this book special? This particular edition of a practical guide to obstetrics, what makes it special? The problem is that most practitioners do not have time to keep up with current literature. We are working crazy hours, particularly obstetricians. Who has the time to turn to journals or to turn to books and keep up with current literature and find out what is the actual data, what is evidence-based? How do we do that? Because we know that it is something that we have to practice, evidence-based medicine. We have to look at data, published data. We have to talk about how we can incorporate it into our practice. And the thing is, how do we filter through all these things? How do we say that these facts are evidence-based? If you go to a conference and somebody comes up and says, this is the way I do it, where is his evidence? Question everything. So how do we know what facts are evidence-based? How do we know which clinical practices should be followed? It has got the consensus of the entire OBGYN panel, and which clinical practices should be avoided. So that is the other last thing is very, very important, because sometimes we get into bad practices. We do things because somebody has done it before us, and we follow wrong practices instead of asking why we are doing it. So in this book, we have used 3 symbols that Nozer had talked about. We have used 3 symbols in the highlighted boxes, and all pages are highlighted. There are a lot of highlights. We have not followed large, chunky paragraphs because it's very difficult to go through it. So each thought or each idea is a bullet point. And it's easy to look at and say, okay, this is what I wanted to know, and I have found it immediately. And then in that itself, we have put a light bulb box, and the light bulb box tells us specifically why that point is very important, and that is something that you should incorporate in your clinical practice. And this also is extremely good for postgraduates who are revising for exams. I remember going to some conferences where youngsters have run up to me and said, ma'am, I passed my MD because of Practical Guide to Obstetrics. Of course, nothing makes an author happier than knowing that you have had an impact on someone's life. So this light bulb box tells you where to look at, what is something that you must keep in your mind when you practice medicine. Then the thumbs up box. The thumbs up boxes tell you this is the current evidence. This is what, it may change. And we know medicine changes when more and more evidence comes in. And we have to change with that. But at present, in 2022, what is the evidence which tells us what we should follow, what we should incorporate into our medical practice? And if you say oxytocin, can we give it concurrently with or with after Foley placement? Or you have a checklist for induction of labor. Make sure that you have this constantly and you go through this every time you decide on induction of labor. Is all this ready? And your younger doctors, your registrars, your junior consultants, all should go follow this process. And this will ensure that the kind of care that your patients are getting in your hospital is absolutely balanced and the same across the board. And then there's the thumbs up. We have questions in our heads all the time because somebody comes and says, or in a conference or a pharma rep comes and says, this is the best thing for you. How do we know? How do we keep on researching? How many times do I have that as a clinician? Can I go looking for this data? Where do I go for the data? Sometimes we don't know where to go, right? So we have taken data from things like UpToDate, from the ACOG, RCOG guidelines across the board. And we have looked at things and told people, when you read this book, if there's a thumbs down, don't do it. This is wrong practice of medicine. And I think in a way it helps because a lot of times we have questions, but we don't have the answers. Most importantly, Practical Guide to Obstetrics is India-centric. I have made sure that we are not just giving, of course, we have to take guidelines from other countries and we can incorporate them. But how does it apply to a low and middle income country like ours? How do we make sure that what we are doing is the right thing for our patients, our women, our families? How are we doing the right thing? And I have made it very, very India-centric. A lot of guidelines have been taken from the Ministry of Health and Family Welfare. And actually, I would strongly suggest that all of you look at those protocols and processes that they have published because it's completely a sea change from what it used to be earlier. They are doing really good work and it's something that you can follow. And it's important because as Nozer mentioned, in a medical legal case, if you say you have followed those guidelines, you are safe, okay? And then again, when we come to things like giving antenatal immunoglobulin, I have never given it in the 28 to 34 weeks because it's extremely expensive. And we are adding one more expense to our mothers. And of course, ultimately, the WHO has also come out saying that you don't give that 28 to 34 week anti-D in non-sensitized women because it is expensive, and especially in countries like ours. In America, where they have more money to burn than we can ever dream of, they can do it. It doesn't matter. But for us, how do we give our conscience and keep our consciences alive when we treat our patients? Again, we have used Indian data. I have scoured the internet. I have scoured the papers. I have gone through it and made sure that we get Indian data. It's not enough to say the cesarean section rate in America or the cesarean section rate in Brazil or in Germany. No, it doesn't matter. What is it here? How do we make a change? And then, of course, because again, when we say anemia in pregnant women, we can't quote data from foreign countries. How many of our women? 85%. This is a paper from Toteja. So we have to follow our own data. And of course, visual learning is very important. All of us learn visually. And so we have given a lot of diagrams. We have spent a lot of time on algorithms, which make it simple and easy for us to remember how to deal with it. And just looking at that can make a difference. COVID-19 came and decimated mothers and babies. And we had to look at this data, and luckily this is because of its the way it had affected the world. There was huge number of data coming in, papers coming in, but we had to sift through that and make sure that it was something that we could actually put down in a book that that doctors and practitioners could follow. So again, we have looked at Indian mortality, Indian data, because it does not matter how many people, mothers or children died in Italy. It matters how many died in India, and because of what lack of infrastructure. We have to know the processes that we should follow. This is something very close to my heart, and this is an entire chapter based on respectful maternity care. It's a human right, and it's something that we have looked at right from the time I started practicing. And I think we have to push this more and more and more. And that's why I think Practical Guide to Obstetrics is an unusual book. Of course, in Essentials of Obstetrics, along with Lakshmi, there too, we have included a chapter on this. Professor Arul Kumaran got me into this whole writing authorship mode, this role of being an author, which I did not think I could do because I was a very busy clinical practitioner, spent many years, months and years burning the midnight oil so that I could write. And now I was very happy that he actually gave us a very good review on this, and he has written the foreword for this book, and it's such an honor and a privilege to have him do that for us. I will now go on to the next program, and I think we're still running on time. Yes, we are only 3 minutes. We are actually 3 minutes ahead. We will now go on to the next part of the program, which is management of pregnancy after assisted reproductive technology. Again, a great pleasure to introduce Lakshmi Seshadri. I would say she is my sister born of another mother. She's my soulmate when it comes to writing books, when it comes to teaching. I did not want to write all her achievements because I would need another 18 slides for that. But to say that she's a teacher, mentor, guide, author, encapsulates what she has done in her life. I will also add that she's a phenomenally wonderful wife and a mother, but then obstetricians and gynecologists learn very quickly how to balance both lives. She's a role model par excellence, and once at a Progress conference when she, Mridu, and I were on stage together, and somebody had asked a question and all three of us said no. And Arjun laughed and he said, 3 tough ladies, okay? And he didn't say use the word ladies, he said broads. He said 3 tough broads, because that's what we are, because we believe very strongly in what we are doing. And Lakshmi, my friend, you have been an inspiration. I was so delighted when you asked me to co-author Essentials of Obstetrics from you, because I had never written for undergrads, and I found out that was an entirely different skill set, and you guided me, and you were a phenomenal teacher for that. Dr. Serena Gilvas, again, a very dear friend, a long-time participant of this. She's a professor and HOD of the OBGYN department at Jubilee Mission Medical College and Hospital. Very well known, very loved for her teaching. She's, I mean, you ask anybody who has graduated from Kerala, and they all love the way she has taught them and given them goals in life. Sheila, my friend, she also shares my gardening passion. Yeah. She is a professor in reproductive medicine, Government Medical College in Trivandrum. She herself is a very well-known author of 3 books, a textbook of obstetrics, textbooks of gynecology, and clinical case discussions. Her books are very popular in Kerala, and she has, she's extremely well thought of as a teacher and a lecturer. Dhanalakshmi is, I have come to know her recently after she took over as secretary for Oxy, And she is professor and senior consultant, Department of Obstetrics and Gynecology at Sri Ramachandra Institute of Higher Education. She is a teacher, undergrad and postgraduate teacher since 1995. And if you talk about somebody who's cool, calm, and collected, that's Dhanalakshmi. Even in the biggest stress of running conferences, she's always has a smile, always seems to have everything under control. And she has a secret skill, and that is making phenomenal videos and brochures for OXI programs. So welcome all of you. Before the last and the youngest one is Divya Selvamani. She impressed me again when I heard her speak at Yuva OXI. And I said she must be part of our panel. She is medical director of Srishti Hospital, and she has been a course coordinator for hysteroscopy workshops. She has special interest in recurrent implantation failure. And to add to all of her achievements, she's also author of the book Alone Together. So Divya, Sheila, Serena, Lakshmi, Dhanalakshmi, thank you all for joining us for this. And now over to you, Lakshmi.
Thank you, Geeta, for that wonderful introduction. Let me start sharing my slide. Okay. Okay.
Yes.
Wonderful, Geeta. Congratulations on the release of that book. I read quite a few chapters on that. Very interesting and a very quick read. I think, it's everything put together, whatever you want to know in one or two chapters, in 2-3 pages. And so it's really a ready reckoner. Students are going to enjoy that. Enjoyed the panel on fibroids, and mine is not going to be that fancy because I can't see much happening in this pregnancy after assisted reproduction. And I have experts on this panel, Serena, Sheila, Dhana, and Divya. So, this is, I still remember the first baby after ART that I delivered, because we started assisted reproductive technique. The department came into being in the early 90s, and the excitement, when that first baby was delivered, I think the whole labor room was abuzz with this, the first IVF baby and first gift baby, etc., etc. And we've come a long way. Now these patients are not as few and far between as they used to be earlier, with the various factors contributing to maybe higher infertility rates or whatever it is. I think we do see a whole lot of them walking into our clinic now, and I think it is important that all of us know. It may not be as common as an ordinary preeclampsia or an anemia, but I think we do come across these patients pretty often. I think my panelists are probably going to tell me much more about this than I would even know what to ask. Now we have I start with the first patient, who's a 37-year-old Mrs. D, married for 8 years, diagnosed to have polycystic ovarian syndrome. The husband had oligoasthenospermia, quite a bad combination. Her body mass index was 31. Her mother was a diabetic. Mrs. D conceived after ICSI IVF with donor sperm and from a frozen embryo transfer. Her meaning, self-explanatory. Her pregnancy was confirmed by serum beta-HCG values. Now, this question I'm asking only for the sake of those who manage pregnancies, who after assisted reproductive techniques, and then the patient has no clue as to her LMP, when what happened, when what medication was given, and you have this paper and all the papers that the patient has brought, and we are wondering, how am I going to calculate this last menstrual period or gestational age? Shall I start with you, Serena? How would you calculate gestational age in ICSI IVF?
So good morning, Dr. Geeta. At the onset, I really want to appreciate you for yet again bringing out another great book. And a hi to Dr. Lakshmi and all my co-panelists. How would you calculate gestational age? So she was actually a PCOS patient who was conceived. Her husband has got oligostenospermia. Her BMI is raised. She's a diabetic. She's conceived after IVF ICSI with a donor sperm and frozen embryo transfer. Pregnancy was confirmed with serum values. How would you calculate? So ICSI IVF, normally when we talk about the gestational age calculation, we always talk about from the date of embryo transfer. So that is normally how we calculate the age, gestational age. It is said that there could be an error if you go by the crown rump length when you do a scan. So they always say that it may be also preferred to calculate the gestational age from the date of ovum pickup. So I don't know. This is all I can think of to answer this question, Dr. Lakshmi.
Would you agree, Sheila?
Yeah. Actually, as Serena, at the outset, I'd like to congratulate Geeta. I was a little busy in the hospital today, so I've only been able to come in between. But really, very nice. I'm very happy to be on the panel. Yes, as Serena already said, we usually calculate it from the day of ovum pickup in a fresh transfer. So if it's a fresh transfer, we put it the date of pickup. If it's a frozen embryo transfer, it depends on whether it was a day 5 or day 3 transfer. So you have to actually go back from the date of embryo transfer. If it's day 5, you have to another 5 days. If it's a day 3 transfer, another 3 days, along with the 14 days to take the LMP. So the LMP will go back like that. So
would you, in a frozen embryo, I agree that in an IVF, most calculate it from the day of ovum pickup, because a transfer could again, it will depend on when the transfer was done. And so this date of ovum pickup should be documented and it always is documented, of course, and I think it's important for us to take a look. For a frozen embryo transfer, would you also use sometimes the date you switch from estrogen to progesterone when you added progesterone for the endometrial thickness?
Because that actually that would probably suppose it's a blastocyst transfer, we give 6 days of progesterone.
Okay.
So and if it's a day 3 transfer, just 1 day progesterone. However much, what is the day of the transfer plus 1 day. So for ease, what we do is we just calculate. You just suppose the patient comes, you've done the ET on such and such a day. You just go back and calculate. So it's 14 days. You think it's 14 days prior to that. You would think the LMP. But then if it's a day 5 transfer, you have to add another 5 days to that.
Oh, no. So then to make it clear, if you're using a frozen embryo transfer, you are not going to be able to, the ovum retrieval, etc. doesn't come in. So you could use the date of embryo transfer note down whether it was a day 5 or a day 3.
Day 5 or day 3 transfer.
Day 3, or you could use the date of progesterone.
You could use the date of progesterone, because most when we send it to fetal medicine centers, they just ask for the date of embryo transfer, whether it was a frozen transfer. So they have this they have this already incorporated into their ultrasound machines for the IVF pregnancies.
Okay, so you need to have either of these documented, and you should most certainly know whether it was a day 3 or a day 5 transfer, so that it may. The thing is, once you do the crown rump length, and there is an inherent difference there. Sometimes it doesn't correlate, and then one starts wondering what is going wrong. Is it kind of is it going to miscarry, whatever, because of the associated problems here. So IVF date of oocyte retrieval, frozen embryo, date of starting the progestin, or with your transfer. Yes, I just wanted to highlight. Now, Dr. Divya, the patient has just come in and she's just, the pregnancy has been just confirmed by serum beta HCG values. Would you like to perform an ultrasound scan now, or wait till she's 11 plus weeks? I'm asking this because I'm not one of those who advocates this so-called dating scan in every woman who walks into the OP. I wait till the 11 till she is 11 plus weeks and do this 11 to 13 plus 6 week scan, which gives all the information, and that is what is recommended now. Unless she has irregular cycles or bleeding or anything, there is no need to do one at 7 weeks, one at 8 weeks, one at 11 weeks. But in a patient who has had this kind of pregnancy, would you like to perform a scan now or wait till 11 weeks? Is an early scan mandatory?
Okay. So first of all, thank you so much, ma'am. I'm truly thrilled to be sharing the same platform, ma'am. Looking at the ultrasound at an earlier stage for somebody who's had an embryo transfer is quite important from our perspective, ma'am. First, to kind of place the gestational sac, whether we've placed it inside the cavity. That's the first thing we're worried about. And so once when the woman's beta HCG shows more than 1,500 or sometimes 2,000, and if the woman's fine, we call them back after a week just to see the placement of the sac inside the gestational age, and look at the number of sacs, because we don't usually transfer more than 2 sacs at that, there are 2 embryos, but basically to look at the number of sacs and to place the intrauterine gestational sac, and that's what we're looking for the earliest scan at that point, ma'am. And maybe once after that, unless she has any complaints or so, we don't kind of see until about the 8 to 10 week scan, just to kind of monitor when to do the exact NT scan for her or plan any other procedures that we are planning to do.
So you're saying that you will do one now at 6 plus,
Yes,
between 6 and 7 weeks, and you would do another one between 8 and 10 weeks, would you? And then do one at 11 to 14 weeks.
Ideally, it wouldn't have been required, ma'am, after we've placed the scan. But then most of the times we do on and off get women with spotting, and I mean, they want to be reassured as well. So
no, if she has no spotting, what is your protocol?
We would do one at 11 to 6 weeks.
You would do one now and one at 11 to
yes, ma'am.
13 weeks.
Yes.
Would you agree with that, Dr. Dhanalakshmi?
Yes, ma'am. Knowing that the pregnancy is inside the uterus, how many over they are, whether singleton or multiple, comforts you first. Because they are known for producing little extra ectopic pregnancy, little extra heterotopic pregnancy. So first thing that should be comforting both the patient and myself will be the location. The rest will fall in line.
Okay, so one now and one at 11, the usual weeks. Sheila seems to be agreeing. I can see that. So ultrasound scan must be performed for location, number, heterotopic and ovarian hyperstimulation syndrome, which seems pretty common. Now, the ultrasonography was done, and this revealed a fetus which was 6 weeks with cardiac activity. The ovaries were enlarged 6 into 8 centimeters and cystic. There was no ascites, and patient just had mild abdominal discomfort. Dr. Dhanalakshmi, would you tell us how you would manage this?
So she falls under OHS 1. So since she's already pregnant, admission I would give her admission, and I'll just monitor her, and with a PCV, axial volume monitoring, and depending on the value every 48 hours, every 24 hours, I might institute the anticoagulation. Best thing would be to put her on good hydration therapy, whether it is oral or intravenous.
Okay.
But even at 6 weeks, hyperemesis shouldn't be preventing her from taking that extra fluids, which is very much.
And if she doesn't, you will probably give her intravenous. Sheila, you would admit her, or would you take her as outpatient because she is not symptomatic?
Yeah, she's not symptomatic. I would do the investigations definitely, hemoglobin and PCV, and I would also have a baseline of the the RF, at least renal function, because in case. So and then I would not admit her, but I would ask her to come every 3 days, or if the distension is increased. I would not start her on anticoagulation if the PCV is normal, unless it's increased. And but otherwise, if there's any problem, I would start her on anticoagulation, and I might admit her. But luckily today we never see this sort of situation, because OHSS has almost disappeared from our practice.
Absolutely,
we all go for frozen embryo transfer in all the hyper responders. So for the last, I think 5 to 6 years, we don't get pregnancy with at all, late onset OHSS.
Yes, late onset. And Divya, what increases the risk of late onset OHS is especially, I mean, or rather, what has helped decrease the incidence of late onset OHS? Can you explain to us?
Number one, since we have moved on to GnRH analog triggers, and we give good luteal phase support, sans the HCG with just progesterone, ma'am, it's kind of generally reduce the late onset OHSs. And in this case, I would probably kind of inform the patient that her symptoms might get worse and before it gets better because of the late onset OHSs. And all she has to do is like be ambulatory and drink to thirst and avoid any kind of pelvic, give her some pelvic rest and hydration definitely, and to contact us if there's any other worsening of symptoms, ma'am.
Okay. Would you say, Sheila, that the risk increases with beta HCG for luteal support rather than progesterone? Dr. Sheila? Dr. Dhanalakshmi, would you say that it increases with the HCG rather than progesterone for luteal phase support? And have you come down on the use of HCG?
Depending on the number of oocytes you see, generally we stop trigger at least for that cycle.
Okay.
Usually these cases are managed by our ART friends.
Okay.
So they are
Fine. Yeah, that is why. I directed it at Sheila, but since she was not there, I thought, okay, I will switch it to you. Okay, Serena, any opinions on this?
Yeah, I just wanted to say an indication for starting anticoagulants in OHSs would be when it is of a severe grade. That's for sure.
Sure.
Second reason we would start it would be if she has had a bad obstetric history in the past and there is history suggestive of an APLA, then yes.
Okay, that is a different scenario altogether, but for OHSs, not indicated yet. I agree with you. Since it is mild, can wait and watch. Close monitoring is mandatory, but she's already 6 weeks. Another week's time, even the late OHSs will settle. Anticoagulation only if severe, sorry about this typo, OHSs or hematocrit increases. If no other risk factors for VTE, need not anticoagulate. Everyone seems to have agreed. In a pregnancy following ICSI IVF with donor sperm, do you anticipate any special problem? Is Sheila not here? Is she not? Hello, Sheila? Geeta, you're muted. Are you saying something?
Yeah, I think she is not here.
Okay, fine. Let me
I've
ask.
lost the connectivity. Yeah.
Okay, fine. So Divya, would you like to take this pregnancy following ICSI IVF with donor sperm? What are the unique problems that you encounter as opposed to the usual IVF or ART?
To be honest, having a donor sperm particularly have not kind of increased the chances of any other problems in the pregnancy, ma'am.
Okay.
Probably the growth potential might kind of slightly be increased when we're going for a frozen embryo transfer, looking at macrosomia, ma'am.
Okay.
Otherwise, we've not seen any kind of particular problems due to donor sperms.
Okay, Dr. Dhanalakshmi?
Well-selected donor, no problem, ma'am.
Okay, Dr.
Sarina,
you were going to say something.
Yeah, I wanted to say something. One is the age of the donor is a very important factor.
Yes,
one.
yes.
And the second thing is they have noticed that there is increase in incidence of pregnancy-induced hypertension in patients when there are donor sperms.
Okay.
Only that condition they have found increase.
The thing that is usually mentioned is that ICSI, especially when it is done for oligoasthenospermia or any of these, is usually done only when there are sperm abnormalities, and therefore there is a higher incidence of genetic or chromosomal aberrations in the sperms themselves, and because and there many of them actually do a workup for the men, genetic studies, before they do even an ICSI with the donor sperm. And therefore, and if the donor sperm does not show any abnormalities, it's fine. But if there is any problem, then you need to certainly be aware that there could be congenital. There is an increased risk of congenital structural, chromosomal, and genetic abnormalities, and this is especially more with the ICSI with the husband's sperm, with the
Yeah.
husband who has an oligospermia. Yes.
Yeah.
If you
In
do
fact,
it with
they've got more incidents of, autosomal translocations, inversions, even even micro
deletions
deletions of the Y
especially, and
chromosomes.
imprinting and various disorders are much more when there is a problem with the sperm, and therefore they need to have a good genetic workup. With the donor sperm, of course, you always need to do a workup on those the donor and the sperm before we do it. So increased risk of structural chromosomal genetic abnormalities. Of course, risk increases if there's oligosperm. Increased
Can
risk
I
of
just say something, Lakshmi?
Yes, please.
Yeah. Okay. See, in ICSI, I think the main things are, one, when you're taking testicular surgical sperm retrieval, especially in if it's non-obstructive azoospermia,
we were waiting for you because we wanted
I'm
this
sorry, my
elaborate
connection
answer.
was,
Please.
yeah. And then, of course, Y microsome deletions is something.
Hello. Hello, Sheila.
Connectivity problems.
I think she's having connectivity problems. I was hoping that she will be there to answer these because she's the one who's dealing with the assisted reproduction. Yeah. Okay. Should I then move on by just saying, well, we'll take this answer from her later when she does join in. Okay. So there's, of course, the increased risk of multiple pregnancy, preeclampsia, preterm labor, everyone knows. And this particular lady, of course, because of her age and the obesity, etc., has gestational diabetes, higher risk of diabetes and preeclampsia. Yes. Are the maternal and perinatal problems different with frozen embryo transfer? I wanted Sheila to be there. Divya, tell us, please.
Yes, ma'am. The with the frozen embryo transfer, we have, because sometimes when we do an artificial cycle with estrogen and progesterone, if it's not in a natural cycle, we do expect a slight increase in the gestational hypertension rates and the gestational diabetes rates as well, ma'am, and a slight increase in preeclampsia as well, and macrosomia, of course, ma'am.
Okay.
I can add one more thing, Dr. Geeta. They say that with frozen, I think they find there's an decreased incidence of SGR babies and preterm labor, and there's in fact an increased birth weight, in fact.
Absolutely, because there are some pluses with the donor, frozen embryo transfer as opposed to the fresh embryo transfer, and growth restriction is one of those. So there are some problems which are definitely less with the frozen embryo transfer. Okay, so now would you?
And also, ma'am, abnormal presentation is also supposed to be lesser with frozen embryo transfer.
Frozen embryo
because of an absence of coprocetium cyst.
Okay.
Particular cycle, because everything is taken over by the consultant. That's what I just read it from up to date.
Okay. Would you, for this lady who has just had an ultrasound scan and 6 weeks pregnant, would you prescribe progesterone, aspirin, HCG, heparin, thyronol? Serena?
Yeah, now most of them are down regulated, and so there is a place for progesterone. Okay, otherwise they would go on for luteal phase insufficiency. Yes. Aspirin, yes, because there's a high.
How long will you give the progesterone, Serena?
Till 12.
Till 12 weeks.
Luteal placental shift.
Okay, well, you wouldn't continue it?
Not necessary.
Considering preterm labor risks, etc.
No, not necessary.
No. Okay, fine. Up to 12
Second
weeks.
is aspirin, yes. And I would give it in the dosage by around 12 weeks. I would start on 150 milligram because she's at increased risk for preeclampsia.
Why? Okay, because of the increased risk of preeclampsia. Is it only because of her ART pregnancy or because of her added risks as well?
No, her added risk, under the gestosis scoring, she would come up very high.
High, okay.
So because of that, I would give aspirin and I would give it a dose of 150 milligrams. Okay. I would give it before the second wave. That is, I would give it around the 12th week.
12 weeks, okay.
150 milligrams. Okay. HCG, no.
No, okay.
Heparin, hers is only a mild OHSS, and so I don't see, and she has got no other risk factors. No for heparin. And unless there is a definite hypothyroidism, no place for thyroid.
No place for that. All of you agree, Divya and Dr. Dhanalakshmi?
Yes.
Okay, so then I will go on. I'm only putting up this list because there are so many people. Have you seen prescriptions following an assisted reproductive technique? Everything under the sun. And if you do not give thyroid supplement, you are not managing infertility. Okay, I mean that is the way it is, and that seems to be the panacea. If you're following an ethical practice, factors. Unless there is definite need for any one of this, we don't. There's also steroid and granulocyte colony stimulating factor on the list. I didn't add because I thought it was really an overkill. Thank you. So, so we will. Yes,
regarding the thyronorm, we do have a low threshold to kind of started when the anti-TPO antibodies are positive, ma'am, and when the TSH is more than 2.5, ma'am.
More than 2.5.
Yes, ma'am.
Is that what you? I mean, that is the general thing that you do a TSH. Now we are all doing a TSH and and a free T4 in pregnancy, and depending on that we start. The cutoff seems to vary. People have elevated it to 4, but I think everybody is still following 2.5 because if there is an abnormality, this is an easily correctable one, and therefore replacement is warranted. Sheila, you are going to say something.
Sorry, Lakshmi, I'm so sorry. This is the hospital and they're going on cutting. I have to be here. Just wanted to reinforce what everyone said. I don't give aspirin unless she's at high risk for preeclampsia as in this case. Heparin is a big no. Even for recurrent implantation failure, I do not give heparin. Only if there is RPL and APLA positive, I give. Steroids, again, a big no. So only progesterone. And if it is a frozen embryo transfer, I would add estrogen probably till 8 weeks.
Till 8 weeks, okay. We were also talking about, I just wanted to complete that answer to that question regarding the ICSI IVF. Yes, ICSI, which is when you got cut off.
Yes. In ICSI, like if it's non-obstruct, absolutely, Y-microsome microdeletions should be done today. Two reasons, because it should not be transmitted, and also you know whether you can get surgical sperm retrieval. And then the other thing is with ICSI, and with the cystic fibrosis, suppose you have unilateral congenital by absence of the VAS, you have to check for cystic fibrosis. And then I think the other thing is after ICSI, even though overall we do not see a problem, there is a slight increase in imprinting disorders, Beckwith-Wiedemann syndrome and things like that. We still don't have very good evidence. The large database has shown there is a slight increase in imprinting disorders.
Thank you.
Sorry again.
Yeah, sure. Okay, so now what first trimester screening test would you order? This lady at certain increased risk with ICSI-IVF 37 years, and therefore we know that we need to do it. What I want to know is which of these, Dr. Dhanalakshmi, ultrasonography, maternal serum biochemistry, non-invasive prenatal testing.
I'll do the first two definitely, madam, and the third one depending on my FTS result, madam. First trimester screening report comes as high risk or intermediate risk.
Okay. So you're saying that only, would you recommend NIPT as the first, as a must in these women? Serena, what is your take on it?
Now this patient of yours is a 37-year-old lady. And so, and many other risk factors, which I don't remember now. So in that case, if I have to check out, I've got a few issues regarding the biochemical markers, because you'll find there's a high level of beta HCG and a low level of PAPA. So sometimes your interpretation can go wrong. One. Problems about taking the NT. So if I've got a doubt, probably my best thing would be to go in for a non-invasive method, like NIPT. But at this point of time, I also want to say there is a place for pre-genetic implantation tests also. So either you can go for the A or for the PGT-A or PGT-M or PGT-SR, depending on what. If you're suspecting translocation, you go for the SR. When you think of the the aneuploidies, you go for the A. And if you got any single gene defects in mind, then you go for the M.
Yeah, but there was no suspicion or anticipation of any chromosomal abnormality in this lady. It's just the age factor and the oligoasthenospermia.
So NIPT should be fine.
Peri-implantation diagnosis was not really in the picture, but when this lady comes, so you're saying that NIPT has a very, very definite role to play. Should I take it like that, or would you offer it as your first line?
No, in this patient, I would, because my biochemical markers might be confusing.
Okay.
That is why.
Which is so in all ART pregnancies. that is because of various factors. I'm sure the others will be able to explain. Divya, can you, why are the maternal serum biochemical markers, they are a little unreliable, right? But not totally.
Because we sometimes in the early pregnancy we do use HCG, ma'am. So the values, we do have labs saying they have validated for HC pregnancies. Yes, but the first trimester screening can also give us an add-on preeclampsia risk as well. So I would still prefer to do the first trimester screening.
So I think most of us continue to do ultrasonography and maternal serum biochemistry, and if there is any suspicion or any high index of suspicion or anticipation, then of course an NIPT. Of course, if the patient can afford it and they really want to know, they opt for it, it's absolutely fine. I just want to emphasize that there is a very definite role for a primary NIPT screening in these ART pregnancies, because biochemical markers are altered, multifetal gestation and vanishing twin is a problem. So NIPT is more accurate and superior. So this lady was offered NIPT. How much time do I have? 12:05. Was offered NIPT, but she decided to have only first trimester screening, including biochemical markers. All were normal. Fasting plasma glucose was 88 milligrams at first visit. Further antenatal care, is there anything special in this lady? Is there anything special that this is a single fetus. The OHSS has kind of settled. Her fasting plasma glucose is 88. She's got all the risk factors. So Dr. Dhanalakshmi, how are you going to manage this lady?
This fasting plasma glucose is little closer to the low limit of normal, madam.
Okay.
So I would
upper limit of normal.
Have her go in for a conventional OGDT, either by DIPSI method or by IADA-based method, as early as possible, as soon as she can tolerate oral glucose. And the further antenatal care shouldn't be differing from any of the other non-ART pregnancies. Iron and calcium at the right time, and injection TD at the right time. And this I'll keep a close watch on her glucose. Madam.
Okay, you will do. Okay. So GTT at 24 weeks, low dose aspirin, all of you have said you will start at 12 weeks, close monitoring of blood pressure, scan at 18 to 20 weeks. So then the next question that I have is, will you monitor fetal growth by a uterine artery Doppler in this lady? Serena, what is your take on it?
Yeah, it is always good to have a uterine artery pulsatility index done. You can do that when you do your 18 to 20 week scan. And along with that, yes, I will monitor her growth, very important, by repeated scans and with the growth curve.
Okay, so what is, Sheila, what is your protocol for ultrasound scan? Let us say you do one at 18 to 20 weeks and the uterine artery Doppler is normal. Okay, if it is abnormal, we are entering into an entirely different scenario. It is normal, but she is on aspirin. When would you repeat it?
I see my patients only up to 20 weeks. After that, I refer them to the obstetrician to be very
Okay, so Serena, take over and tell me, when will you, what will you do?
See, after 20 weeks, the scans are done for growth, and it is done at least minimum of 2-week interval.
So even though the uterine artery Doppler is normal, after 20 weeks, are you going to scan them at 22, 24, 26?
The uterine artery Doppler will tell me only about the preeclampsia part of it.
Okay, I agree. But are you going to monitor growth every 2 weeks from
Actually,
20 weeks? On?
If you ask me, do I do it? No, I wouldn't do it.
No, you wouldn't do it. So what would be your recommendation? Dr. Dekshin, I mean, wouldn't you just, if everything is normal, clinically she is growing well, would you really do it every 2 weeks? Most probably not, right? Dr. Dhanalakshmi, how would you manage her?
At 20 weeks, you'll have an idea whether the baby is going for lower centiles, madam.
Okay.
If it is well below the 350 grams, kind of we keep a cutoff for the baby's weight at around 20 weeks as 350 grams. But say lesser than 300 grams, I would keep a close watch on her.
Fine. No, what I'm talking about a scenario when everything is normal.
Okay.
At 20 weeks.
No, I wouldn't be repeating it.
Okay. So when will your next ultrasound scan for fetal growth be?
28 would be
28 weeks, and then if at 20, and you might do 2 because at 28 weeks and 32 weeks to see the interval growth, and if everything is normal, you will take it from there. Okay, so the recommendation also is that by the NICE and other that if you might do a uterine artery Doppler, especially in women at high risk, like age more than 35 years, BMI more than, she does fall into that category, nullipara ART, pregnancy nullipara with ART, other risk factor. So So do one at 13 weeks and 24 weeks, and serial umbilical Doppler for fetal growth in third trimester if any of this is abnormal. That is only in third trimester. If at 32 weeks umbilical artery normal, then you will just follow her up as usual and manage her. Do I take it that you all agree?
Yes.
Okay.
Just one more thing, hello, ma'am.
Yes,
around between the 18 to 22 weeks, we also usually couple it up with fetal echo. So those women who've been having PCOS or with an increased, low threshold for GDM. So just know, because that is one opportunity to look at the fetal heart. So at 24 weeks, when between 18 to 24 weeks, when we subject them to
fetal
yes,
echo.
ma'am.
Yeah, that is probably.
I think there are people who are routinely doing. Some people are routinely doing fetal echo now.
Exactly. I think some Tamil Nadu government actually insists that you do it. So now it comes to the question: when will you? When will you deliver her? She's no problem. Singleton, 37-year-old, normal sugars, no growth restriction. When will you deliver? I will ask each one of you, or if everybody agrees on one, I'm fine with it. Sheila, when would you recommend?
I think she can go right up to term. 38 weeks is no problem. Absolutely no problem.
39 weeks, 40 weeks?
39 weeks even.
To 40, okay. Serena?
38. 38 to 39 is what I would
38 to Dhanalakshmi?
Near term, madam. Anytime beyond 38 weeks, madam.
After 38, correct.
After 38.
After 38. Divya, you're smiling. Are you going to deliver early?
No, ma'am. No way, ma'am. I would like to increase the chance of having a child.
So let us say that there is no need to really deliver early. Absolutely. But then when you say after 38, I am, I'm a teacher. I want I want a number on it. So would you, let us say she comes for a checkup at 38. Are you going to say, okay, get admitted, I'll deliver tomorrow? Are you going 39. To say 39 is fine? 40, definitely, I agree. You're not going to add on any more complications to this. You may not wait till 40. So will you start 39. The process at 39 weeks or 38 weeks?
38, I will start doing fetal monitoring, madam. I'll start doing 39 weeks.
Okay, so what is your protocol? Serena, you see a patient like this in your outpatient clinic. When do you admit her for delivery?
Yeah. If I want her to, now this patient, I might even give her a chance for vaginal delivery. Then the ideal time to induce would be 39.
39.
Okay, because their response to induction is best when it is 39, like
so
but if I'm planning a section between 38 and 39 weeks, I would have done a planned section.
Okay, planned section. So if I'm still talking about a vaginal delivery, let us say not beyond 40, 39 weeks, you start the process. Okay, but acceptable to do it if there is a problem anytime after. But I'm not talking about a patient with a problem. Uncomplicated, can be delivered at term. Stillbirth rate is twofold higher, so advised to deliver before. Do not wait after 40. No randomized trials and no definite guideline to say deliver at 38, deliver at 39. Now comes the $1 million question. What would be the mode of delivery? I'll start with Divya.
I definitely would want to have vaginal birth for her, ma'am. So usually what we do. So that's why beyond 39 weeks, we start doing cervical
You induce and usual protocol. So you're saying vaginal.
Yes,
Dr. Dhanalakshmi?
Depends on the
this is the patient. She's
fine. Willing for vaginal delivery, I'll give her, madam. I'll give her all support. My full support, including epidural analgesia during
vaginal. Serena, vaginal?
I'll keep her for a vaginal delivery, no doubt, and with the low threshold for cesarean. At the drop of a hat, I will do a cesarean.
You will section her. Sheila?
I agree with Serena.
You agree. So what I want to emphasize...
Talk to the patient also and take her views also into account.
Absolutely. Okay. Younger women with... Okay, agreed. And complicated singleton pregnancy can be delivered vaginally. Discussion with a couple is mandatory. I think her opinion should be taken into consideration. Low threshold for cesarean section, absolutely, you taken the words out of my mouth, Serena, and you individualize. So what I'm trying to convey to the other practicing obstetricians is that there is no need to section all of them. ART is not an indication for cesarean section. ART is not an indication for delivery at 37 weeks or at very early in pregnancy. ART is not an indication for monitoring for growth scan if they are uncomplicated. Majority of the singleton pregnancies following ART actually behave very well. and do not have any problems.
Dr. Lakshmi, can I say one thing?
Yes,
do you know
please.
when our best success has been? When the
Yes.
patient wants to deliver vaginally.
Yes,
If she says that,
absolutely,
you know,
I agree with
can I have a vaginal delivery? Then in
Yes.
my mind, I've ticked off, she will deliver.
Yes.
Anytime it
If
happens.
they are very nervous and ask for a section and you are telling them,
Yeah,
no,
then
no,
it will never
then
work.
you have a problem. Yeah, practically we have a lot of issues. So in this slide, I just have 2 more slides to, you know, because that first trimester ultrasonography revealed 3 embryos. Okay, I just want, Sheila, would you highlight the guidelines?
I think today the ART Act has also come in. If you're putting, I mean, most of us are doing blastocyst transfer. If it's a good blastocyst, definitely a single embryo transfer. And that's what I follow. But if it's day 3 embryos, it depends upon the age. Suppose she's more than 35, day 3 embryo, as cleavage stage embryos, I might put back 2. But blastocyst, definitely good blastocyst.
Only single, absolutely. So, and everyone follows the guidelines, and we don't put in anything more than 2, irrespective of, and therefore this complication is very unlikely. Now, if you do come across this, will you offer a fetal reduction? Is the question. Dr. Dhanalakshmi, you will? Sorry, yes, Sheila?
No, it's okay. Yeah, I would talk to the patient, and, you know, I think it's very important because it's triplets. Quadruplets, definitely. I mean, if it's quadruplets, definitely you would offer. In triplets, I think we would talk to the patient and then decide, look at the chorionicity and all these things, and then take a decision.
Okay, and then take a decision, but you will certainly consider. Divya, you agree?
Yes, ma'am, because
you will reduce it to 1 or 2?
2.
2. Okay.
That's what we do.
Right. I think I'll skip these. Just to say that after fetal reduction, there is an increase in the risk of miscarriage, which you should certainly think in terms of. So I'll stop here.
One point here, Lakshmi, cerclage. Because unnecessary cerclage is being done for all IVF pregnancies. So do you want to just comment on that?
Not indicated,
It is certainly not indicated. I didn't even think that people were doing right. Okay, right. So thank you very much, panelists and audience.
So it was a panel. I'd like to profusely thank Geeta ma'am for including me in progress for the first time, and I'm also happy to be sharing this platform with my postgraduate teacher, Dr. Sheila Balakrishnan, and teachers of all ages, Dr. Lakshmi ma'am and Dr. Sarita ma'am, and my young colleague, Dr. Divya, the upcoming one, whom I really admired during our Khalid, our Yuva Oxy conference. Thank you so much.
Thanks to Geeta, Lakshmi, and everybody. And I'm very sorry for my bad connection. I apologize profusely.
No, I mean, but then you did come back and give us your valuable opinion. So anything that I have not covered, I would like Serena, Sheila, Dr. Dhanalakshmi, Divya, please, whatever points that you need.
I'd just like to add a point here, Dr. Lakshmi.
Yes.
See, whenever you get a heterotropic pregnancy, there are 2 things you should remember. One is the patient normally will present with pain, and many times they may not have bleeding because there is a fetus inside. So whenever a patient comes with pain, yes, the chances of heterotropic pregnancy should be borne in mind. Second thing is, if it is a heterotropic, only laparoscopy. No question of any.
Okay, and I think we should, when you do an ultrasound scan in the first trimester following that, the 6-week scan, I think you have to look at the tubes, whatever. You have to make it a habit because of that.
Can I also add something?
Yes, Dr. Shobha. Yes.
Yeah. Hello. Yeah, I just thought that maybe it is the appropriate time to bring in the concept for FGR screening for both early onset and late onset. And the ultrasound that we offer between 24 and 30 weeks should screen for the early onset. And I think all of us can together say that, but after 32, 34 weeks, we need to keep on a watch for the late onset FGR. And that will help us in categorizing women into, because often the late onset FGR gets missed.
Yes,
and the early onset is diagnosed a bit late than it is desired. Yeah.
Okay. Point taken. Yes, Sheila.
Yeah, just 2 points I'd like to add. One is when we have frozen embryo today, we are seeing more and more of most clinics are going to frozen embryo transfer. And we are finding all the literature is showing an increase in hypertension and large for gestational babies with frozen transfer. Now, this risk is mainly, it's related to the HRT cycles. So when natural cycles are there, this risk is not seen. It's because when the natural cycle FET is done, you have a corpus luteum which produces relaxin and preeclampsia is less. So this is something I think which, as when the patient comes to you, you can check her this thing and go into her IVF records and see if it is a frozen cycle, if it was a HRT cycle or a natural cycle. The second thing is donor. Many times IVF centers do not give whether it's a donor, and that is very important. We are trying in this, I'm in the state board, and we're trying to reinforce that whether it is a donor sperm, it has to be written because of the high risk of preeclampsia. If it is an ovum donor, the age of the donor must be specified. This is something which we are trying to do.
Thank you. Thank you. These are practical tips from people who are practicing assisted reproductive. So, Geeta, over to you.
Thank you so much, Lakshmi. It was a joy to see you and the four of the panelists interact. I think a lot of questions were answered because, as obstetricians who don't practice IVF, they need to know what to expect, from you, because they, an obstetrician is going to see the mother all of a sudden, and they don't know what exactly to protocols that have to be followed. And I think all of you were extraordinarily clear. And I hope the participants understand that these are people who talk what they preach. They're not just going to say something and do something. So it's very important that, particularly in a case like this, to go and do a cesarean at 34 because she was an IVF pregnancy, or to do a cesarean at, you can give her a vaginal delivery. Of course, no question about it. Most obstetricians across the world have a very low threshold for delivering mothers who are conceived after ART. There is no doubt about it. And I think the mothers are also extremely concerned. The families are concerned. We should pay attention to that. I'm not very convinced about the 39 weeks because we know there's enough data to show that Indian babies mature much earlier, a week earlier than Western babies. So I am much more for the 38 weeks. And there is enough data about Indian born women, Bangladeshis in the UK. Their meconium shows up earlier, they deliver earlier. In India itself, the data has shown clearly that we deliver earlier. We don't go to that because remember earlier they used to say postterm was 42 weeks. Whoever saw 42 weeks, right? So for us, 40 weeks itself was postterm. So, you have to start planning your delivery for a woman who's not had any of these. By 40 weeks, you have to start planning her delivery so that she's delivered by 41. So in the same way, I would still personally say 38 weeks. So start planning at 37 so that she's delivered by 38 weeks. I am not very comfortable about 39 weeks because we have seen enough meconium.
Yeah, Geeta, it is because of this Indian babies maturing early that we move from 42 to 41, 41 to 40, 41 to 39. So I think I'm comfortable at 39. I don't know about the others, but yes, I take your point.
Right. So I don't know if there are any questions. No questions.
No questions.
No questions. Anyway, thank you so much. Thank you to Oxy. Thank you to University Press. I think the University Press team has been phenomenal. I'm so sorry about your throat, Sheila. I realize you're having a bad throat and bad connection. And of course, Shobha also had a bad connection. And I think she's working out of some place just to be on the panel. And I am so thankful for all of you for having taken the time to come and help us inaugurate this and launch this book. For all the participants, it's available on Amazon. And any of you want to tell your postgraduates, whatever, it's available on
Geeta, I just want to say that yesterday, I went through your book because I got it only yesterday. I just went through a couple of chapters beautifully, all the shortcuts, everything is written, and I like the boxes. It's a ready reckoner, no doubt. I'll definitely recommend it in our society also.
Thank you. Thank you so much, Sheila. It means a lot for authors like you to say that.
It's very easy as a ready reckoner for people like me who are, little bit we are away from obstetrics. Thanks a lot.
Right. Thank you. Thank you so much. Thanks to all of you. Yes, Premalata, you're muted. You're muted, Premalata.
Thank you, madam, for the wonderful opportunity to be associated with Progress.
And thanks for letting Oxy 2022 team to finish it in style, ma'am.
Dhanalakshmi, this is the first time I have done progress with another outside society. And I'm so pleased it was you and Premlata and the entire team. Rajji also is part of Oxy, Divya, all of you. I'm so glad and thank you so much.
Does this mean that progress is going to continue?
$1 million question to Geeta. Geeta, let me see you answer that.
Geeta, is this a forerunner of things to come?
No, for physical progress cannot run. It's just too much time and stress rather than anything else. So 2017 was the last one.
Yeah.
So I think these kind of progresses will continue and I hope to continue like this. Maybe 2024, I know we have another book coming. I also have another non-medical book coming up. So let's see.
Very good.
Thank you, ma'am.
Looking
It's going to rock as well, ma'am.
Thank you. Thank you.
Thank you, ma'am.
Thanks, everyone.
Thank you, ma'am.
Thanks.
Thank you all.
God bless you.
Universities Press, thank you so much for the support.
Thank
Thank you.
Thank you, Hari. And thank you, Madhu and Malini, for being my absolute support systems. Thank you so much.
Sarina, happy to see you, Sarina.
Thank you. Thank you.
I must, Dr. Geeta, I must apologize if my attendance has been a bit patchy. The annual conference of Bangalore Society is going on.
I saw that. I knew you were in a conference.
Yes,
ma'am. They say you're going back and forth. Amazing.
I couldn't miss this. And I have already gone through considerable bit of the book and I am in love with it. I'm going to teach my postgraduates from it. And
I'm so happy.
wonderful.
That really makes me glad because it's important coming from somebody as good a teacher.
We have 3 classes a week, so ample opportunities.
Thank you. Thank you, Shobha.
Thank you.
Thank you. Thanks, everyone.
Thank
and
you,
bye.
ma'am.
Bye. Bye.
God bless, ma'am. Thank you, ma'am.
God bless you.
Thank you again, university's team. It was without a glitch and went off wonderfully. Thank you again.
Thank you, Dr. Geeta. It's always a pleasure to work with you.
Thank you, Madhu. Thank you so much.
Okay.
Bye, Malini. Bye. Sudha, I think you have to leave early.
Sure.
Okay. Thank you again, Madhu. Hari and Prashant.
Thank you, ma'am.
Flawless,
Thank you, ma'am.
flawless. Very good. Thank you. Bye.
Bye, ma'am.